There's a lot more, of course, we could do. We could treat her nasolabials, but I think, you know, we've made her suffer enough. So we're going to clean her up and we're going to have a look. Clean. Yes. Could you clean her a little bit? Okay. So what we did, basically, we were treating her most important areas, which are, of course, the infraorbital or the malar area, the nasal bridge, and the chin. And of course, we should also inject the nasolabial folds. However, with limited amounts of product and limited amounts of time in this case, we should stop and go to the next patient. If you have any questions, please feel free to take the microphone and ask questions. It's almost 1 ml that I inject, almost 1.5 ml. Let's see. It's 1.2 ml. 1.2. 1.2. If you start, you mean this starting point? Actually, I prefer this entry point, and the reason is that from here you can not only go here and here, but you can also go down to the columella. Of course, it's also possible with the needle to go into the columella, but with a cannula you can really go down alongside. You can breathe through your mouth. Breathe, open. So you lift the nose. Go with the cannula, go down through the columella. You can even go through the muscle, and you can go and you can lift the tip of the nose. Relax. I don't have any needles.
Yeah,
okay. So, of course, from here, my problem with this entry point is that you need to bend the cannula because if you look at it from the side, you want to go here. The syringe and the cannula might be touching the hair, and it's a little bit more difficult to get all the way down here. So, I mean, you know, it's just a preference. It's just something that, you know, slowly but surely I have accustomed myself to. And of course, it's also possible to go from here. Thank you for that question. Any more?
One more from my side.
It was the same type of cannula. It was 25 gauge, 5 centimeters. Exactly. I used only one. And actually, you know, I know that Softflow wants to sell a lot of different cannulas, but I have found out that if you take just one and get to know this one very well, then you can do almost anything because you get used to the flexibility of it, and you get used to the length, and you can get used to the rigidness of it. So, yeah, of course, different products can require different cannulas. But for radius, 25 gauge is really the best, I think. Yes, I use the same dilution for the nose. So if I have nose indication, usually what I do is I start the treatment of the nose with undiluted radius, but I usually only use about 0.2 to 0.5 mLs for a nose. So it leaves me a lot of radius. So then I mix the leftover radius with the lidocaine. Do we have the before and after pictures? The before pictures? Who took them? We have to put it on the screen. They want to see it. And actually, I'm curious too. And as you can see, she might need a little bit more. I already injected here in the mental crease, but she does need a little bit more. But you can see that, you know, from the side, the chin is improved. Okay.
Angle of the laboratory. Angle.
Okay, there's a question about mandibular aging. Yes, the mandible changes dramatically when we age. When in a young female, the mandible is very angular. With an old female, the angle gets resorbed and changes. So there's bone resorption at the mandibular level. So the cheek kind of sags down, and it gets stopped by the mandibular retaining ligament. So it creates the jowl and the prejowl sulcus. So if you want to lift this inferior cheek back to where it came from, you should have a mandibular augmentation. What you can do is you can take a needle and you can go and find the mandibular angle, and you can just place multiple little boluses on the periosteum. Or if you prefer to work with cannula, you can go with a cannula, but you have to be at the dorsal side of the mandibular angle. So it's really here, not here, but it's here. And go to the preauricular area. Even sometimes you can go behind the ear in order to pull back the skin. And you can put a layer of radius here with a fanning technique with a cannula superficially in order to create neocollagenesis, and that will contract the skin and will give you a lifting effect of the cheek. Okay, if we have no more questions, or do we? Then we're going to leave this lovely lady alone, and she can have a look in the mirror. And you know, the nice thing about this is this treatment is focused on natural aging process. So what is happening here at the malar area, the zygoma, at the deep fat, the superficial skin, this is all very predictable. And so the volume loss here is very pronounced. And so if you replace lost volume, you will actually reconstruct the youthful anatomy, and therefore is a very natural rejuvenation. So that's why it's important to make pictures from before, because we will go back to the original anatomy. Okay, thank you very much.
Thank you.
Thank you, thank you, thank you.
I have a baby hand.
Baby hands. So the nurse should get back in here. We're so lost without the nurses. The nurses are so important to us. We always give him the idea that they're not doing their jobs right, but actually we cannot live without them. Sometimes when I'm alone in my clinic, my nurses are not around, I don't know where anything is. I'm looking in every drawer until I find the right cannula. Yes, thank you. How old are you? Juliana, was it?
Lena.
Lena.
43.
43. 43
and half.
and half. Okay, so we are going to try. She's 43 and a half. We're going to try and make her look 43. So we have to take 6 months off.
Mm-hmm.
Is that enough?
No, I want,
you want
36, 38.
Oh my God. we have to take out 4, 5, 6 years.
No, if it's possible.
7. Okay, we're gonna try 4.3 years.
Okay.
Okay. And actually, Elena has very good skin, see, and she has very good volume, especially in the anterior cheek. She lacks a little bit of volume in the lateral cheek, and she has a beginning of a depression of the temporal area. She has mild concavity of her frontal area. She has pronounced nasolabials. She has a reduced mental area. So what we're going to do is we're going to focus, firstly, we're going to inject in the temporal area. And then the cheeks, I'm going to show you a needle technique instead of a cannula technique. Do we have some gloves, my dear? Thank you. Okay, did you prepare a syringe? No, Not yet.
Check.
Okay, could you prepare a syringe? Okay, so we're going to continue with the treatments. Let's think about the temporal area for a moment. So the danger zones of the temporal area are obvious to us. It is the superficial temporal artery. And of course, according to the anatomy books, the superficial temporal artery should be located somewhere here below the hairline. And in the case of Elena, I can feel it right here. And you know, this is the normal location of the superficial temporal artery, but sometimes it is running right through the area that we want to treat. This is the area that we want to treat, because here I see the depression. So what we'll do is also mark a little bit the blood vessels, and in between I see an opening, and I check again for pulse. There is no pulsation palpable over here, so I know this is quite safe. Is this new?
Yes.
It's not necessary, but just to kill a little bit of time, I will give her a bleb of Lido. And then I will go to radius with a needle. Oh, it's not done yet? Okay, so in the meantime, I will mark the rest of the face. Of course, there's the infraorbital foramen. We have to be careful, especially if we inject with needles. So this is the no-go area. You can really feel the depression here. Okay, then the infraorbital rim. Then the alar tragal line. Then the zygomatic arch and the vector line. And again, you can see where there's a nasojugal groove, you can see this little triangle here. So with the cannula, you can go from here, treat this area. You can go from here, treat this area. With a needle, what you can do, you can go along this line and inject every centimeter. And from this line, inject every centimeter. So you can inject here, you can inject here, you can inject here. You can inject here, you can inject here. And from here, you can do either going straight down to the bone or going just slightly up. But don't go very superficial in this area where you have the malar ligament inserting into the skin. Also, we're going to go to the nasolabial folds. And of course, when we go to the nasolabial folds, we have to be aware of the arteries. We know, of course, from the common carotid artery, which has a pulse here, that there is the external carotid artery, and then there's a facial artery. Now, there's a submental artery that we previously discussed, but there's also the inferior labial artery, and there is the superior labial artery, and there is the angular artery, the lateral nasal artery, and it's going up the nose and actually going into the eye. So in theory, if you would inject with a needle in the nasolabial fold, and if you would inject into the artery, there is a chance that the product could end up in the eye. There are actually some cases reported of patients that became blind after filler injection inside the artery. Okay, so I have my radius, and I go through the skin, and the patient can hear some strange noises. You can zoom in. I'm through the skin, I go through the fascia, I go through the muscle until I reach the periosteum. I feel the periosteum. Now she feels some pressure, and she's going to hear some noises when I inject 0.1. I retract, reorient, readvance, another 0.1. On the periosteum, I leave my needle on the periosteum. Why do I do this? Slow injection with low volume. The reason is I want to avoid intravascular injection. The same goes here. There are direct connections from the arteries, and some of these arteries are running over the periosteum. There are arteries in connection with the central retinal artery. And therefore, we have to be smart. So we use low volume and low pressure. Low volume, because if you are in an artery, then you limit the embolization. Low pressure, because if you are in an artery, you inject intra-arterial, then there is a lower chance of the product going retrograde into the arterial system of the eye. So I injected 0.3. I will go to the other side. I will do the same there. Okay. I palpate. Do I feel pulsation? No. So I can go in, I go through the skin, I can feel the resistance of the fascia, I go through the muscle until I reach the periosteum. Then I give 0.1, very slowly. Okay, I have a needle block. I was touching the periosteum too hard. When you go too much into the periosteum, then a little bit of periosteum might get stuck inside the needle. This is a disadvantage of a very thin needle. But in that respect, a thicker needle with a larger lumen is easier. So I go in again, 1, 2, 3, through the fascia, through the muscle, onto the periosteum. I give 0.1. Retract, reorient, readvance, 0.1. And just next to it, maybe half a centimeter next to it, I give 0.1. Okay. Now this is a chewing muscle. Sometimes the patients will tell you that when they open their mouth, they will feel some sensation, like some pressure. Also, some patients think that there is a hole with a direct access to the brain over here. Of course, this is not true, but somehow they get this idea. So we can reassure those patients that there is still the skull protecting the brain from the needle. So I'm going to start right here. 1, 2, 3. I go in, give a small bolus. Can you see it? Is it okay on the screen?
Yeah.
There's 0.1. Another 0.1. And then press. 0.1. If there's any questions, please feel free to ask me.
If you could turn the head like that, it's better for the...
Sorry?
The head a little bit. Sorry.
Okay. But of course, you know, this is exactly what that lady from the audience asked, and this is a perfect way of treating the zygoma. So over here, I feel more comfortable using a retrograde fanning technique also